But living with dementia, whatever stage that might be, or young people because their frontal lobe until 18 is not mature yet, the anxiety, the concerns, the worry continues. So it's important that we learn how to breathe. Breathing is important, and with the help of caffeine, it'll be fine. So I'll talk about breathing. Have you heard about box breathing before? Yeah. You have? Yeah. So I'll do my way of box breathing because I cannot do 5 seconds. I do 3 seconds. It's too long. So imagine that I were to breathe because I really want to make sure that I'm able to process what I do. So let's breathe together. So we'll do, think about, oh, I haven't got a marker, but let's say if there's a box. Box. So I want us to breathe in. So imagine when we breathe in, you take 3 seconds to breathe. So let's breathe in slowly. But once you breathe in, you must stop for 3 seconds. Yes? Then you breathe away for 3 seconds and you stop again. So there's 3 seconds, 3 seconds, 3 seconds, 3 seconds. 3 seconds. Oh, that's a long one. 3 seconds, 3 seconds. Let's do it. Let's breathe in. Inhale for 3 seconds. 1, 2, 3. Stop. 1, 2, 3. Breathe away for 3 seconds. Then you repeat the process. Okay? If you do that, your lungs will receive about, or hopefully half a liter of air, which contains oxygen 20%. And that part of the oxygen saturations will go to your brain. Oxygen makes us alert, makes us happy. And I'll tell you how oxygen itself, how exercise itself, how meditation itself. Meditation means not to sit like a Buddha in a lotus position. It's to be able to regulate our breathing so that we allow more heart flow into our heart chambers that pumps up blood to the aorta, to the lung, to the brain, to the feet, and we can be thinking with better clarity. Alright? So let's say, back to this picture, if you are happy, that means it's better for the heart. Happy people are not going to have fast heartbeat. Alright? Number 1. Fast heartbeat means the heart will doop, rest, doop, rest. So it will squeeze, rest, allow blood flow in, squeeze. We have to learn how to breathe again. We have to allow for the oxygen to go to all chambers of the brain so that the heart doesn't do this. When the heart does this, it's not allowing blood or contraction or pumping of the heart output properly that disseminate good circulation from a physiology of the brain. So if you breathe better, you live better. Right? Easy, with a big smile. So, back to the story of this. This is at the Queen Elizabeth. There are a few hospitals, and I was very lucky that I was trained here. The hospital that I was trained is part of the central Birmingham. It's not just because it's next to a chocolate factory, which I love, but it's about it was the first hospital in the world that started a false clinic. You know? There's a lot of world's first on research and dementia. Alright? But not much world's first on how to care for people with dementia. It's all very, very scientific, I think. But it's still important. One thing that I wanted to do is how can we change how we care for people in our environment. That could be hospitals called Acute, or it could be community, like a facility at home. Now, there are works done, back to you, there's that work done by a group of researchers wanting to know how long does staff or workers in aged care socially interact with their residents. So, Mealtime is not counted. Medication is not social. Showering is not social. Social means, how are you today, Tati? Are you in control of your limbic system? Yes. How long do you reckon in a shift of 6 hours, or sometimes 8, depending on where you are, the aged care workers socially interacted with a resident or their resident on average in 6 hours? 10 minutes. Anyone? Any more takers? 10 minutes. Huh? One. Who said 1 minute? 2 minutes, sorry. 2 minutes. 2 minutes in 6 hours. 2 minutes. 6 minutes per client to help them to get dressed, to shower them. But imagine that 6 minutes will be meaningful and engaging, right? Because they have 80 to support. 80, on average, 80 to 100. That's how things are. And how do you use $6 per meal to make sure the food on the table is pleasant to see and tastes as good, right? I was at a Qantas lounge in Adelaide and in Melbourne. It's all vegan food yesterday. I was so distraught. I said, oh my God, I can't go with it. I'm going to kill myself. Sorry. I'm joking. I'm joking. It tasted nicer. So what I'm meant to say is, back to this, if we can demonstrate to our government, politicians, CEOs, or whoever the leaders are in northern Tasmania, why don't we have expert volunteers in our acute care hospitals, in aged care? But must allow time for the workers to train the volunteers, right? That's important. If they can do this and it becomes part of the national standard, that means the volunteers become expert volunteers, right? Then it can become the best hospital in Australia. Yes, Denise, which is the best hospital in Australia last year from a consumer experience? Of course, the Queen Elizabeth, of course, in Adelaide, in this country. Easy. Easy. I do not like hospital gowns. I would say please change, if possible, to the person's usual clothing, attire. It's not hard. Please allow single, one gender wards. It's not difficult, right? It's not difficult. Please ensure our hospitals, our facility know when not and when to give drugs to modulate change behaviors. Alright? Example, anti-anxiety, antidepressant, antipsychotic, pain relief. So in some centers in the world, in this hospital I used to work in like Scandinavia, you go, as you arrive to the ward, there's a big TV. And the big TV is located as you come in to the ward that you visit. And you can know, this is called dashboard. Great. Dashboard means, like let's say today, somebody had a fall, but none last week. So the graph will go one like that, you know, one fall this week. Infection like MRSA or C. difficile, 2 cases this week. And then they've got a table, what happened last month with these documents. Imagine suddenly that naughty ward Denise has got 10 use of respirator. Woo! Who's that naughty doctor, please? We have to educate them.
Even worse, it's haloperidol.
Yeah. So vitamin H, haloperidol, I managed to remove from our hospitals except for certain situations only. We'll talk about that later in the after lunch, I think. So, I believe if we are providing services, it has to be accessible, respecting of people, cultures, language, and belief. If I were to have dementia, Amanda, you must speak to me first in Indonesian, Malaysian, Japanese, Arabic, then maybe English. Okay? You must learn 4 languages. Otherwise, it's not going to happen. And bring my 400 parrots with me. And Kentucky Fried Chicken every night. But that's how I am.
But I'm your baby's toilet tray.
That's right. And everybody Like, you know, Barbie, you are unique. You're God's creation. You are yourself, right? You don't want me to give you KFC every night to eat? No. So that's what we do in hospital. That's what we do in our clinics. We tend to echo what we are, which is not right. We cannot do that. We are comfortable in our shoes, which is okay. But what if you are able to have systems or processes or robots that can help? This is Daniel, used to be our lead volunteer for the hospital before I left. So with this system, my life story, the family can come and visit someone at Launceston or Burnie or Alberston local hospital, and they can email or share mums or dads, husband, spouse, wife's favorite music, albums from many parts of the world. Then you can have a program to be able to show, today we have a diary, what to do. It's not just about medication, it's about working with our lifestyle therapists, pet therapy. Maybe we can have an engagement when you have visits from the young generation. So what I'm trying to tell you, this is me in Japan, in Kyoto. So if you go to some nursing homes in Japan, there's Pepper the robot. It costs $15,000. It's not expensive. 15,000, which your organization can buy. What I'm trying to say is that there are ways for you to have let's say if you choose a facility in this part of area, to have Pepper the robot that can engage with people living in a facility in your clinic. How to be able to greet. I think it can dance as well. But what I meant to say is this: we do not need to have robots to do this. I go to Japan every year except before COVID, and I stopped. I now go for holidays only. In Japan, I asked Professor Emeritus Akira Homa, I said, sensei, teacher, I said to him, I want to learn about robotics. I said, while my other degrees in England is Masters in Health Informatics. I learned about AI in London. I want to introduce robotics, AI in our care system. But he says, no Faizal-san, no Faizal-san. It's you and I, how we communicate. It's not the robots, right?
Right.
Yeah, this is the person that trained, the one that makes sure people wear an orange band, right? So what it is, simple stuff. So this is retired matron Island Seals. Back in those days, she wants to do a research to see if her nurses, her staff at Guy's and Thomas's, if you think about Guy's and St. Thomas's hospitals, it's across the Big Ben, the Westminster, the Parliament, it's across it. So she is was the matron, and she covers Whip's Cross and stuff like that. If we can allow our consumer to finish their sentence without stopping them, then we've reached a lot already. We've done a lot. I find it hard to do because I've got a lot of things to do with that guy. So I'm trying to train my brain to think differently. Imagine 10 years from now, when I'm 65 years old, when I come again, Denise will be 21 then, Denise. Alberston will be the first city, or even Devonport maybe, or Launceston, whatever you pick, the first city in Tasmania that is dementia friendly truly. Stirling is a small city in Scotland. So from the pedestrian, the bus seating arrangement, the colour, I was at the Novotel Hotel in Devonport. They failed their dementia healing audit severely. It's a beautiful spanking new. The carpets, if I were to have dementia, Amanda, it would look like I'm going into this void of tornado. Yeah, I can't process. And the floor, the carpets are arranged. This is a box carpet, so it's not a rolled carpet. When you arrange your carpet in a wrong way, it feels like its space is not right. It's not. It's level, but in my brain it was like that. Okay? So you must be able to tell yourself where you work, where you care or caregiving person with dementia or delirium, whether you've passed the audit call, environmental healing audit. Okay, it's funded or it's done by a group of experts by using the King's Fund, so King's College in London data. So if you Google it, you can download it, then you can say, okay, my office passed, my office failed. It's important. The first thing is about environment. The temperature must set at number 23 degrees. That's the temperature set in aeroplanes. Do you know what temperature is set in your work office, Denise?
Depends on who's in the office.
Depends on who. 23. I like it 19, but 23. So the temperature, if it's too cold, you visit number 1 toilet often. The caffeine. People say, oh, stop drinking tea. Drink green tea, has got a lot of caffeine. The only tea has no caffeine will be your fruit tea, your chamomile, and your rhubarb tea. But people like tea because it's the purple part of the brain, right? It's memories, right? So, but start maybe less after 6 p.m. in the evening. The thing with coffee is wonderful. Coffee has got a lot. So coffee can increase heart rate, so limbic system is affected. You're waking up. But coffee also means if it's too much, it affects concentration. So sometimes it's good to invest on decaffeinated coffee if coffee lifestyle is really important for that person living with dementia. Now, I have to skip a lot because I know I won't be able to go through my 484 slides. So I work here. My ward is on the ground floor. And this is where I used to work in Liverpool, in Sydney. So I was a specialist there in 2006. It's a long time ago, right? Then I went back to England where I came, and I think if you were to have a map of your connections, your team players, your supporters, your champions, make sure that you have your arms stretched everywhere. So I work at, used to be this hospital. The current hospital is also called the Queen Elizabeth. I don't know why. And I teach as the honorary lecturer at medical school, and I support and service specialists for Port Lincoln and the Peninsula. And I used to work for the State Service Director for Dementia Australia for many years for people at the change behaviour. But my current job, and still is Dementia Australia, and then I work as a clinical specialist associate for 3 states. And I love what I do. It's a passion of mine. When you love what you do, it's like a hobby. How can it be hard? Right? How can it be difficult? Because the moment I sit in clinic, I must exude confidence and happiness, right? Even after a long and a busy day, isn't it, Denise? Isn't it lame? Isn't it lame? Isn't it everybody? We have to exude confidence and kind. Hey, I don't know why this is like this. Hey, sometimes. So I wasn't lying about being the best hospital in Australia. So we won as the best hospital. Not because we have the most expensive equipment, not because we have the most doctors or nurses, but we have how we care for people. So this is voted by the Australian Patients Consumer Association. That is something I'm proud of. All right? Now, imagine if this is our new hospital. These are my aunties. So adopted aunties in a way. All were retired matrons. Midwife, and she used to be the diabetic director of the Queen Elizabeth. And I feel that even we know we work in healthcare, but when we ourselves part of the system or a patient, we might see the reality side of it, right? So Auntie Helen was receiving cancer care 6 months ago. And I bet you she got so many stories to share with you. The good and not so good at all. But what I want to tell you, if have anyone been to recently and visited the new hospital that we have in Adelaide? This is world's most expensive hospital. The 3rd most expensive building in the world. Number 1 is which building, Denise? Dubai. You know the Burj Al Khalifa? Yeah, number 1. Number 2, Singapore. You know with the swimming pool with the ship? Yeah, number 3 is Royal, the new Royal Adelaide Hospital. The medication is selected by robots. The food is delivered by robots. Do you think this will change if the consumer care is not good? No. This is my sister hospital. So I take older person or post-surgical under our care because Queen Liz Adelaide is a centre for geriatrics and rehabilitation. So people come in there first and they come to our hospital. New buildings doesn't mean that they become great hospitals. It's how we care, how we support. I wanted to share you an important work that we did, and I'm not certain whether it's happening in this part of Tasmania, but many years ago I was in the taxi with Professor Mark Yates. So he's like me, a geriatrician. He's based in Victoria, and he also teaches at the Deakin University. And one thing that I know, I said to Mark, how come we're not making education for dementia compulsory in this country? We have to do it. So Mark said, let me think about it. And then months later, he wrote to me, I've got a few $1 million by Commonwealth government, federal. I think we should do a program, and the program that was done is obviously taking lessons learned from his hospital, his team, and what we're doing is to check at any time, because we know in the UK, at any time, 40% of people in our hospital have got dementia. We just do not know which one yet. Okay? So we must have a question, how many percent of people at any time in the 4 hospitals, or we call pilot hospitals in Australia at that time, so the Queen Elizabeth, which is Adelaide, then you have Tasmania Royal Hobart Hospital working with the geriatrician and the lead directorate nursing allied health, and in Perth, Charles Gairdner, and also in Canberra. 4 hospitals to become the thermostat. Do you know, at that time we had no knowledge, Denise, how many percent of people in our hospital have got dementia or delirium? No knowledge. If you go to geriatrics ward, you might be able to do it. What about surgical ward? What about ICU? And we have no knowledge. How are we going to make dementia care super sexy so that we can reduce stigma, timely diagnose? We can't. We do not know who comes today have got dementia. So the project was done. We've done a pre-intervention. We knew at our hospital we only screened 6%. Now, if we were to teach not just our clinician, that means doctors, nurses, allied health, what if we were to teach the admin staff, ancillary staff? What about the cooks and the chef, the porters, the security, about dementia, delirium? Maybe we can improve awareness. So we spent months to do pre-intervention. And I said, how on earth I'm going to ask our cooks for the hospital to come up to hear me talk like this for an hour? It's not going to happen, right? So 5 slides rolling in the kitchen to tell them what is dementia. To the porters, if someone has got dementia, we will introduce to you a concept, a symbol that we put on the bedside, on the computer framework, so that you're kinder to that person, please. You work with the family because the family might be the one that can help to make sure every day is titanium day, not like glass breaking into a billion pieces. Right? So what we did, we spent a lot of time. Remember, the funding was limited. And if we were to screen in our hospital 90% of people coming to emergency room and to 10 wards, medical, surgical, we can demonstrate, we can confirm and replicate what was found in England before I left. So in the UK, at any time, 40% of people in hospital have got dementia. Delirium, 30%. Nursing homes, 60 to 70% guaranteed. And also the abuse and misuse of antipsychotic, right? Those are the 4 things that we must know and learn. And what if we know, we screen, we ask the right question using the right tool that is supporting or respectful of the person's language and belief and stuff, and we can confirm that person has got dementia or delirium, this symbol would come if you were to see your brother in the past, you know that your brother is living with delirium. And what it means is not to stigmatize them, be kinder with him. Using 9 processes conversation. Introduce yourself with the right language. I'm Faizal, with a smile. Number 2, make sure you have eye contact at all times. Not too close like this though. And involve carers. Remain calm and talk in a matter of fact way. And there's a few more. And repeat yourself. And do not give too many choices. Now, would you like to have KFC, McDonald's, Hungry Jack's for dinner? Too many choices. No good. So what I'm trying to say, this becomes a top 5 or 2. And once we've done this, we must make sure we keep on reminding our team, our staff, our students. We do master class like this. Master class must be also a simulation. So this afternoon, not today, I'll be asking Denise to wear a wig and a face mask, and she will become 100 years old young lady. And her voice must be hoarse, and we'll put her on the chair, and we'll get you to the front actor, and I'll say, Denise, please throw a glass of water to Tatum's face. That's called hyperactive delirium. And what would you do to resolve? De-escalate. So we do this because we send our nursing staff to Queensland to use mass processes to do simulation, practical training. People do not like talking like this too much. They want to do hands-on stuff. Make sense? I think. So back to this. Whose business is this dementia? Everybody's business.
Yeah.
It's not just the doctors only. It's not the nurses. Everybody was. Remember, we even trained the cooks. We chose a tool that lasts 2 minutes, not 10 minutes. A tool that we call 480, which I'll show to you towards the end. It's 2 minutes that could encompass dementia and delirium. 2 minutes is not long. And if we need to do it, we'll get a family or a translator to translate. Once we screen them, then we do those things, either an MSc. That means if we say in our ward, being a geriatric ward or ICU, being highly intensive, we ask our nurse, whoever is there first, do it. Somebody must admit the person. The rule is within 24 hours. We have to repeat it again. If it's positive, certain points need to be scored. This is up, we work with the family, and when this is up, we're going to do 1, 2, 3, 4, 5, 6, 7, 8. What we've done, we wanted to influence the government. The reason is this, to make training compulsory. How many years now training becomes compulsory? 3 years, 4 years, compulsory. From 6% to 94%. So no excuse, must be done. We win. What I meant, they want to show, we showed them. 2 minutes is not long, it's everybody's business. How come someone tell me, oh, I haven't got time for this? Well, isn't it number 1 cause of death? Isn't it is a number 1 cause of this burden in this country? Isn't it the one that impacts a lot of people, loved ones? Isn't it? Isn't it means that if we can support this better, people would not be prematurely admitted into nursing home and die faster? It would, wouldn't it? So these things needs to happen. And maybe that was the only way to influence change. And it's working. So I believe if this can be done in Wyler Hospital, in Port Lincoln, in Victor Harbour, why cannot it be done here? So we need more Denises, more Laneses, more Lynn, and more all of you to do this, more voices. If there's one Denise standing here, there'll be Amanda, there'll be Graham, there'll be all of you standing there behind, right?
Yes.
Correct? True? Okay.
Good answer, Amanda.
Good answer. Now, imagine my ward. If you see this, it means it could be dementia or delirium. If it's dementia, it will stay there. What it means is that the food trolley is close by. Help the person. Fill the menu card. Get the family. Help them to understand what dementia is. Not 2 minutes or 6 hours, right? It's not going to work. And that's how we become the Australian best hospital. Now, I know in Port Lincoln it's smaller. We haven't got brain machines like MRI or PET. That doesn't make a good hospital. What makes a good hospital is the ability to change, to adapt. So this is the agency that I'm working for since 2010. You used to work for Alzheimer's, it's called Dementia Australia. So our program is called Nightingale. Maybe in the future, I can connect you with Jane so that you can do a Teams talk conversation. And then who knows, in the future there might be a process. You can have a Nightingale program in Tasmania. Then I'll be involved then. So life is short, smile. What important is this. What I'm doing today is what I've done often. I like talking. I feel that if I talk to my Gambia, we do let me again simulation. I love sharing knowledge and learning from people. Like when we did this, where in, I can't remember now, this is Mount Gambia. And I did this in Canberra. And this is why I said, you get one of the staff with a wig. So maybe in the future I can get Brenda to pretend. Become really hyper-stimulated. And then we can ask everybody to come and text us to see how to change behavior. Right? Then we'll get an expert to stand, 5 of them, maybe a clinician, expert nurse, OT, consumer. Say, that's not how we do it. Do it like this. Again, there are many people who go to you the knees and say, cannot be done. Delete them immediately. Delete them. I know people ask me, why did you spend your holidays going to Borneo again, Faizal, year 4, year 5? Because I was born in Malaysia. I know I grew up in Ireland and in England, but that's my birth country. So the consular of Malaysia said, do you know? I said, I know. Australia is the same. In 2050, 300% increment or prevalence of dementia. That is a fact. What are we going to do about it? Maybe more situations like this, more connection, engaging with consumers. So what I did, this was last 14 May, just 2 or 3 weeks ago. I went again to a place called Kuching, Borneo, Cat City. Kuching in Malay, in English, means cat. Maybe at that time there were many tigers there, but no tigers now, just cats. It's called Cat City. And my ex-PhD students, and so I would go every year. This was arranged by the Kuala Lumpur Health Ministry for me to do healthy aging. Example, next year after, engage a bigger platform, perhaps a community center, have 15 tables, one to do free vaccination, one to do COP screening, one to do content inspect product, one to do dietetics, one physio, one talking about Reiki, one talking about respect, one talking about palliative care, and have 300 to 500 people come. And that's what we did the whole day. This was on the, I don't know what date is that. And then, but that was the first time in my life I was asked to speak in Malay language to talk. Oh my God, I did well. I just talk. But people, the first half an hour, it wasn't talking. I will get everyone to stand, not now. Do breathing exercise with music. Why? There are a few things we can do so that we reduce our risk of getting Alzheimer's, for instance. So this is the week after in Borneo. She was, Dr. Sally is my ex-PhD student. The only PhD graduate in frailty in Malaysia. Isn't that wonderful? Yeah. So when she was with us for 3 years in Adelaide, she said, I've got so many bosses who doesn't understand dementia. I know, Sally. You have to become an oyster with a pearl. The pearl is hidden inside the oyster. Okay? It's different to gold, shining. Everyone knows about it. Everyone wants gold. But imagine the pearl hidden for many years. When it's open, then you become the thing that people look at. Would you like to buy pearl or gold? Pearl. So she's now pearl of many colors. She's done the project for 4 years. So this is year 4, year 3. And what she did was open 13 clinics. I know it's only 13 minutes from here, from Alveston to go to Devonport. She has to take a boat for 2 hours, to go to clinics. There are 13 regional clinics. She called it gecko because there are many lizards in the jungle. Gecko. What she did was screening in a Malaysian language. It can be done. It can be done. And what she did, she said, Faizal, after 3 years, I demonstrated that just by healthy aging, living better, and then screening, people are living longer in my district in Kuching for 6 more years. Isn't that wonderful? Do you know average lifespan of people living in Alveston? They know it in Borneo. Used to be called leather-head hunters. Maybe it's how you need to get your oysters with pearl hidden that needs to be opened now. You can become like Dr. Sally. Easy. Now, if people ask me, Amanda, how do I talk about dementia, something about more clinic. So if I talk too much clinic, stop. Clinic means, let's say if I see somebody here, in my mind, I must make sure that me and that person can connect. The first principle of memory services is this: willingness to receive treatment and connect. Correct? Some people do not want to come. I cannot change that. But I will do my best to connect them to the right person, maybe. So when someone comes to see me, I must know what age group. The average lifespan of people living in the Egyptian, Ramses II? I lived in Egypt for a year, years ago, so I'm so enamored with Egypt. What's the average lifespan during the Ramses, 4,000, 3,000 years ago?
It's about 40 something.
32. So 32 years old is bye-bye to the world at that time. Now, I think in Australia, 75 years old. In Malaysia, 70 years old with average. The average lifespan of people move and live in nursing home in Australia is 2 years. These are facts. What if we can make it longer? What if we can change the gatepost to longer? Right? How we did 4,000 years ago, and now science, medication, good care, vaccinations, antibiotics, right? Imaging, cancer care. What if I were to tell you, younger age group, the commonest type of dementia syndrome out of 129 is Alzheimer's disease. Who is Alzheimer's person? Who was he? Limbic system? Who was he? A boy or girl? Boy. Where was he from? He's dead now. Bavaria, that's somewhere in Germany. So his first name is Alex, so Alois. When he coined the term Alzheimer's, just looking at case studies of a lady called Augustus Dieter. She has got, they're uncertain what she was having, but that itself, as she passed, and they look into the slides of her brain layers, they can see a lot of shrinking of the temporal, the green one, the parietal, and the frontal. Now we know for certain, because we have histopathology, we have imaging, we have lots of modalities to do it. So Alzheimer's disease, coined after a psychiatrist called Professor Alex Alzheimer's, 120 years ago, is a term that we use. They are mixed up Alzheimer's with something else. One is vascular type dementia, dementia that leads to premature aging of the vessel of the brain. Example, diabetes that's not well controlled, or diabetes long-term with age that would result almost the same, or too much lifestyle changes that's not good, smoking, drinking too much, sedentary lifestyle. And one of the risks of getting Alzheimer's is low education exposure. Sometimes it just happens. Some people live in a place that are displaced, war, so they miss schooling. It doesn't mean they are short, it's just how things are. So if we can change 12 things that we do in life, like be active, be happy, learn new things. We can go through University of Life after we retire from work, right? We can learn new languages. How many languages do you speak, Helen? Wonderful. So that is important. That becomes the purple part of your brain. So imagine if you don't learn new things, you're allowing every day your brain cells to die faster. So lesson number 1, brain. Keep brain active. Start to learn new things that makes you happy. What makes you happy, Graham, other than a man?
Go.
Oh, God. There you go. You must do more things that make you happy. What do you love, Brenda? Chocolate. Oh my God. I only eat white chocolate. I don't know why I'm allergic to the dark ones. It will be great. But imagine to make Brenda happy. Chocolates of all varieties and colors. The next, if you look at this, frontotemporal type dementia, alcohol-related dementia. Whatever it is, Lewy body, Huntington's and other, what it means is that it's the care that we provide to them. There must be timely diagnosis. There must be awareness of stigma risk in younger persons that we care for. Allowance for them to be able to work as long as physically and mentally possible. Support their young family, right? And offer treatment research trials if we can do it. This is how we should do it. The thing with, as we become older, then the change, the landscape change when Alzheimer's becomes predominant. It actually, if I were to take people's scans here now, if you're 70 years and above, I can tell you 30% of you would have Alzheimer's plaque. Smile. Smile. If you're 85, half. Smile. But there are drugs now, I'm not going to talk much until I reveal, that maybe at the beginning of Alzheimer's, it can stop the plaques from making things worse. But we haven't reached the point how we can deliver to our public Australian patients yet. It's just been approved last week by TGA, I'll tell you a little bit more shortly. So we've heard about dementia syndrome, the umbrella. The thing that saddens me if I see somebody after many years, they ask me, what is the difference between Alzheimer's and dementia? I said, wow, where did you go in those past clinics with me that I smile and give all the handouts? Thing? It's because they were focusing on emotion and the sadness. I'm talking about the caregivers and the family. If we can work with them, link them to Dementia Australia, Care Beyond Cure, Cognitive Pathway Assessment ClinicServices, Palliative Care, Tasmanian, everything, to make sense that life itself is terminal. Why don't we live the best of our life if we have 12 months or more or less, right? Yes. So, I have a story, more stories than she, sorry. You must remind me about the time I can't forget this situation, this scenario of a 100 years old Italian lady that I looked after under my care. I think this must be 14 years ago. So she came into the Queen Elizabeth Hospital in Adelaide. And 40% of my patients speaks Italian first, or Greek first, or Polish, or Russian, or Vietnamese, right? And she speaks only Italian. And my team, my staff, can speak some languages. But that day we did not understand her at all. The family was very distressed. And when they're distressed, they feel that emotionally they're not coping with mom's agitation. So they stop coming. And sometimes the way to heal is to have some respite themselves. And that's how people need to do things sometimes, to break away for a short term and be involved on the phone if emergency. So she became the world's strongest granny. Oh my God, she would take her frame and kick and stuff like that, try to break the glass. Wow! And we are afraid none of the drugs that we use in dementia we've ever tested in 100 years old. You see, I don't know whether it works. But we tried, and she became drowsy and fell. So we are afraid. Then she tried. She doesn't want people to change her path, which is hard because that's about dignity. That's about how she presents herself. And she would use her frame as an armor. That's hard too. And our staff needs protection and understanding. They said, I cannot look after her. I got bruises on my arm. So we have to understand that too. And she's afraid. That morning, the third day, my secretary Connie Falcone came to support, just to ask me. He said, is this your patient? She's telling me all of this. I said, tell me. What? Oh, she said she's 21 years old. She's got a son who's 3 and a baby girl who's at home. And her husband is out in the vineyards doing work. And he'd be angry at her if the meal is not done on the table, right? And I said, and she was apparently talking a dialect of Calabrese Italian, which nobody seems to click because we assume Italians speak the same language. Just like Indonesian have got 200 plus dialects, right? Like that. Imagine that, no, we did this. We do not want already to use restraints. One thing that I believe that people do, not because of ill intention, but poor system that let people down, is the abuse of restraints. Physical restraints, chemical restraints, vitamin H, haloperidol. I've never seen restraints in my life used in England, in Sydney, until I came to Adelaide, in my life. And I don't understand this. People use it, but I said, why? Why are we doing this? I don't understand. So I said, it's nobody's fault. We have to change. So we remove the shackles completely. We've removed vitamin H. We don't like vitamin H, do we? Haloperidol. We change something more dignified, more safe from a stroke risk. And same goes with this patient. We need to understand about how our body feels. At what time of the day, Brenda, do you get most tired?
8 o'clock.
Oh, you're not far. So as a human being, includes anybody, including those living with dementia. At 7 o'clock, remember we slept, we go into delta, theta, our brain starts to heal. Some can't because of pain, stress, worry, or dementia, or random eye movement disorder. You wake up feeling already stimulated, more confused, more tired, more fatigued. Take picture please for this one. Then at 1 p.m. it becomes higher, the accumulative stress to the body. This happens to all of us. And that's why some parts of the world, they promote sleep, right? Siesta, afternoon nap. Then 7 o'clock, it becomes worse. So that's why in our hospitals, we stopped having nursing handover at 7 in the morning, 1 p.m. and 7 p.m. We have to give drugs that change behaviors an hour before that becomes peak. So if I were to see in hospitals in Adelaide or Port Lincoln or wherever I help, when they're antipsychotic, to help that person to live better with less agitation is prescribed after 8 or as given at 10, I get very angry because the drug is not going to work. It's wasting money. The drug is not a sleeping tablet. It must be given before the accumulation stress to the brain becomes. How often the nurses here give drugs at 10 o'clock, antipsychotic like Risperdal? Hands up. Nobody? Do you give drugs antipsychotic after 8? 5 o'clock? Nobody gives antipsychotic? Wonderful. Okay. But if you do, there's a problem there. Knowledge. So we need to work with the GP, with the specialists, with the doctors to understand dementia. Okay? This is what we have commissioned, auditors, national care guidelines to guide people to do their job better. Education. Agreed, Amanda? If people do not know, how on earth are you going to know? Don't share knowledge with you, right? So we need to educate our patients and the caregivers, become expert caregivers, expert patients. And one of them, understanding risk. This was done by a team sponsored by Commonwealth, by, at that time, Dementia Australia, DVDANS at that time. Now, the solution for that case was, I said to my team in hospital, at a hospital, and it so happens with my work, my job with Dignity in Care Australia that we introduced, we had Maggie Beer as our patron. Maggie Beer has got a nice farm shop. I'm promoting Barossa Maggie Beer farm shop. Pheasant pate, all those things, right? But Maggie Beer, 2010, we drove to see her. Maggie, I need your help because I'm not sure who to ask in Australia to become the face and ambassador for dignity in care. I need someone that can influence many things, but food is of importance. Who do not love KFC? She hates KFC, by the way, so she doesn't like it. So she said, Faizal, I'm thinking about this. I was even thinking how angry I'd become. She just came back from Victoria to visit. I'm not sure, I think there was like a school planting vegetables and stuff, but something about facilities, nursing home in Victoria. And she was angry to see the food served on plates in aged care was not dignified. Everything is blended and pureed like a... Why do we use foam? Why do we use mold? Why don't we make it more tantalizing to the eyes and the taste? Knowing as with dementia, the visual field change, the taste change, you like things are sweeter and more tastier, maybe saltier. So she said, my vision is to give scholarships to our aged care cooks and chefs. And she's done that already. She's done a book, yellow color, called 101 Recipes for Alzheimer's Disease. You can Google that, you can Amazon that. What I'm trying to tell you, the lady, 100 years old, Sue Ellen Taumina, who was at that time our Alzheimer's South Australia lifestyle person, made her own baby dolls. Now, I'll ask you, Marina, the secret to baby dolls, the eyes must be open or shut.
Question. I've seen a few with the baby dolls, but I think the ones we had were open or they could close as well.
It must be shut all the time. Because then the my patient will think, she's not going to sleep. There'll be a problem. And the feeling must as if a texture, and she'll plant the hair one by hand. And they will put a pacemaker. So it must be real. You go into the world of the person living with dementia. You must make sure you present the color, the texture, as if it belongs to someone from that part of Italy. It worked. She became the world's kindest granny and happy until the time for her to go into an Italian-specific nursing home. Where at that time in 2012, Denise, SA ambulance due to infection control do not allow baby dolls unless it's so injection. So we had an engagement after, now baby dolls are allowed in transit. That's how system can fail us badly, right? So connection. So dignity in care means not just about hospitals, aged care, SA ambulance services, all those things. So this is Professor Akira Homa, who's retired. Remember the guy that I said, I want to learn about robotics. I said, no, it's you and me. I said, okay, I'm going to teach you about baby dolls. There you go, baby dolls. Okay? So what I'm trying to tell you is this. When dignity is present in all of us, okay, we feel in control. We feel valued, confident. We are able to make our comfortable decisions, and then by supporting them. So I always believe that if we can have a good, clear guide in dementia, it must use the 10 principles of dignity in care. The guide are accessible from the platform, from online interface. If you just Google Dementia Australia, you get all of this, all right? It would say, at that time, reverse to what Keith Paston said. It's very factual. We know it's a terminal condition, right? But do you want us to be reminded of that every day? Now, when I showed that in 2011, 2012, in our consumer forum, people don't like it. But I showed them. Then I said, why am I doing this? Why don't we give hope to people? Why don't we help them to live a happy and, if possible, longer life? Make sense? So I'm not going to show you that video. If you want, you can have copies of that from Lane. Is that okay? Yeah. So I'm not going to do a human anatomy cross-section of the brain, but you have a nicer version on your table, the colorful ones. This is the boring one, okay? See, Graham, this is how the brain looks like. In my clinic, I've got a rubber version of the brain in pink. And I said, this is how heavy our brain is. It's quite heavy, actually. But a lot of the brain is actual cholesterol or fat. Then you have the white and the gray matter. The white matter, Graham, is like the insulation of this one. Inside is the copper wire. So the brain has got gray, the cells protected by the insulation. And within it is got a fluid built around. in the skull, in place. So imagine we have this part, it becomes the control system. This is the green part of your brain, temporal. This is the red part. Remember I went to you and asked you to remember 5 items. And then you have frontal lobe, Donald Trump problem. So imagine. So this is how I like it to show you, how the video I like to show. I choose this way. Make sense? Now you know we have 2 types of memory. I hope today I can help you to understand that the most important thing in life is our emotional memory. Correct? That's important. How do we achieve that? If you look hard within you, you'll find the answer. Okay? Because mine will be my many parrots at home. Now, I'm not going to tell you too much about this because what it is stated in that colorful print at the front. When you do dementia, you must not forget the 3 Ds. Dementia, delirium, depression. That is the brain. I look after a lot of people who's got significant or life-debilitating mental health. So dementia is one aspect, like depression, bipolar, schizophrenia, late onset schizophrenia, post-traumatic, PTSD. Example, my patient who has dementia, if they are from Vietnam, Denise, or Cambodia, they come to me under my care with PTSD, then dementia. I notice what they see in their brain is different. What I see in their brain is this. In their brain, because they had to leave or got displaced from Cambodia. Vietnam, we call it the killing fields. In Cambodia, the Khmer Rouge. They lose families, friends in front of them. And when they do this with dementia, the part of the brain called the occipital comes up in their mind. When they see, we can't see it. They call it, they see dead bodies under the hospital bed, behind the pots at home, or behind the wardrobe. But people who have not been through PTSD, they might see children or dogs or animals, or people who are no longer living. Imagine you see dead bodies every night under your bed. That's not very pleasant, is it? So it's important for us to unpack those emotions. Why did I show this and skip the previous slide? Because remember the 15 years of not having quite dementia yet, in the brain? Remember I asked you, if I do a lumbar puncture, do a scan, you want to know? So let's say if not you, someone else come to see you, and their memory is not great, the green part, the short term is not great, but they are still able to function like before. The memory sometimes comes back. So when you lose one domain of the brain, let's say the memory, but you're physically able to preserve your physical function day to day, we call it pre-dementia, or the medical term is mild cognitive impairment. So if someone has got mild cognitive impairment, the older they become, if they're above 85 years old, half of them most likely will change into the most commonest type and form of dementia, called Alzheimer's disease. We can actually predict that now. Do you want to know whether you have dementia? If you do, then you will be thinking about what can I do not to get it, right? That's important. So I'll tell you how I do it, not to get it, okay? So sometimes when we do this, we talk about how does dementia affect our sensory. Imagine we talk about colors just now. I'm wearing not quite blue, but like a light blue, still wearing that, so that I'm trying to promote to you primary colors. What are primary colors?
Yellow, red, blue.
And the fourth one? Green. If you wear this, like the German artist called William Aftermolen in Germany, so he was diagnosed with a type variant of Alzheimer's disease many years ago, 1996. He was an artist. He likes to draw portraits of faces. But you see his brain is interpreting colors differently, right? From color with clear eyes, nose, smiles with the hair, eyebrows, up to the year 2000, after 6-7 years, that's how the stages of dementia changed. And that's when the color becomes as if I told you about baby month 1, month 2, the color differ back to the color of just that. So as a care worker, as a clinician, as a family member supporting someone with dementia at that stage, we need to ask, is he or she seeing me like that? So use the power of, are you okay? Lots of smile today. Yes? Cannot say, are you okay? Because it's not visual thing. Right? Use the power of, yay. Like that, we have to change. We have to have the superpower to suddenly become a dementia expert. At that time, Amanda, you are already expert. Okay? Smile. What I'm trying to say is this, people around us are looking at you to guide us. Graham, how much do you love Amanda?
100%.
I can 2,000. I can see it. As I say this to you, your heartstrings are touched. Do you love Graham much more?
Oh yes.
Of course. You chose each other in this world to be forever, right? And whatever emotions you have will keep in the future. That's how I remember my mom, who never scolded me. Sometimes embarrassed me with, oh, I love you, so my place. That would never change. If you keep those memories in your occipital, your purple zone of your brain, 30 years from now, wherever you are, might be, people remember you as a loving and happy couple. Correct? True? That's what I think. Now, how do we stage dementia? So, who is the youngest one in this room? I'm 55, not the youngest. Who's the youngest one in this room? Who's the youngest one in this room? Have a guess. I think.
I thought you were, sorry.
No. I think you are. I think you are.
Probably, yeah.
Oh, yes, her. Yes, you are. The youngest one. You're right. Back to you. How do you stage dementia severity? And the answer is not MMSE. If you were trying to tell me, you've just seen a client, a patient, a consumer in this setting, and he or she has got Alzheimer's disease. And the next thing I'll ask you, what stage is the person in, please, Jess? How do you stage the severity? I'll tell you. I thought you were going to look at your colleague and say, what's your name, please?
Oh, Robin.
Robin. Do you know how we stage dementia severity in Australia? It's used in 1988 by a group of called Riceberg. And what they say is this, we use the functional deficit as the brain loses the green power left and right, the blue power left and right, the orange power, which is your functional, frontal, high exact sequencing, initiating awareness, when you have 40% loss of your green and your blue, we call it mild stage Alzheimer's disease. Yes? When the person, it's 15 years of this, 15 years of that just don't know, or she doesn't want to scan her brain because she doesn't want to know. But say if that person has got dementia, just mild dementia means you've lost 40% of the temporal, which is the green part, and then the blue part, and that's when the person will need help with things that's higher function, like bill pay. Usually, when you have mild dementia, the frontal lobe will be affected a little bit too. When you lose 60% of the part of the green, the blue, temporal, parietal, and affecting more of the frontal lobe, the person needs support to choose clothes, attire every day. And that's what we call moderate stage Alzheimer's disease or moderate stage dementia of whatever type. The moment they need one person to be there to help with not just choosing clothes, but putting them on, bathing, toileting, we call it moderately to severe. And lastly, the final 12 months of life, is needing two people to help with communication, all the things that you can see to support them. My job is to tell person how long it takes to get that. I do not know. It's important that when we do our assessment as a therapist, as a clinician, we know how to stage dementia. To present to each other. I've just seen this person who's got Alzheimer's, we think, because that's what the doctor said, and the scale of dementia, we call it fast functional assessment scale number 5. So please ensure that we help the family process to choose attire clothes, lay on the bed, or hang it in a perspective and see the colors and put the day Monday to Sunday example. Yes? That's how we do it. Let's say if then we need to know how do we then talk about behavior or change in behaviors. I talked about, we don't use the word BPSD, did we? Change behaviors means what are the primary behaviors? So example, the lady 100 years old, she was agitated because she was worried. She was concerned, why is she not at home with the young kids at home, right? So look at a triangle. The triangle is done by emeritus or retired Professor Henry Brodacki, who worked in Sydney at Prince Charles as a senior psychiatrist. And he and his team actually started Australia's first flying squad for change behaviors. That means someone call and fly over, not fly over, drive or whatever. And the job that I did for many years, for 13 years until recently, was to lead our state team for DBMAT, so what we call them change to DSA Hammond Care. Same thing, but how we communicate. First, the person's demographic profile, where, location, what type of dementia, what fast scale. Then, if I say 100 years old, stage 6, because she is very agitated. She wants to go home, right? Number 6. And what we did as a team, we gave her a baby doll. The baby doll reduced from number 6 to number 2 or number 3. Dementia, but no problem with behaviors. Some people use drugs, pain relief. Some people choose an environment, a better lighting, a better room temperature for the bedroom. Example, a kinder carer to look after them and give them a respite so that everyone can hear and see. That's how we communicate. Types of dementia, first a bit of profiling, who's at home, what supports. Then we talk what type, what scale severity, and then change behavior. The language is 5 lines. Then we might add, if you become our clinical team for Nightingale, I want to hear the term about frailty score, AKPS, speak score, so many scores, Rockwood. No, talk about that today. Then we can plan for that final 12 months pattern. Then understanding the person. If my patients, if my consumer, my clients in Port Lincoln, they might be farmers or retired farmers. So the drugs must be changed according to his or her usual, life story. So as opposed to if they're up at 3 o'clock in the morning, so this graph changed earlier, right? That's how we medicate them. That's how we know them. Now, this is the one that I'm going to show very, very briefly. My mom had vascular Alzheimer's type dementia. And what I know is this, because everyone is different. This is just work done by a colleague he's a psychiatrist called John O'Brien in Cambridge, in England. He wanted to know, when you talk about dementia type, how long can people live on average? Some people live longer, some less. That's what it is, because there's so many variants in types and factor of frailty, how old they are, right? And how good care they receive. So on average, it's for male, it's 6 to 7 years. Lewy body dementia is a bit different. So Lewy body dementia needs 3 hours of my time to share with you what we learn. Lewy body dementia means the person's symptoms are quite different. When they present with Lewy body dementia, has anyone here seen or supported or cared for or has got Lewy body dementia? Lewy body dementia means the person brain changed differently. The brain scans would be different too. So there be some temporal lobe change, but sparing of the posterior cingulate gyrus. I'll show you the picture afterwards. But also the person will have this hallucination and describe like, I was in Borneo 2 weeks ago, right, and Kuala Lumpur. I talked to many young doctors. None of them Have you read the book Gulliver's Travel? Oh no, you haven't? Have you? Gulliver's Travel? No. Who has read the book? So you must be young. Have you never heard of Gulliver's Travel? You've heard Gulliver's Travel, right? The one there's Lilliput, yeah. So it's a sailor woke up and then somehow woke up in an island with little people. Lilliput. So people with Lewy bodies is little people or little animals with abstract colors. They also have cognition that change, fluctuations in their memory, like, oh, good day, not so good day, different to Alzheimer's. And they have what we call spontaneous Parkinsonism. And not just that, they have problem with sleep. It's called random eye movement disorder. So when they sleep, they get stuck in the middle or random eye. So that's when they move their arm, move their leg, and the hand. So, and lastly, it's about my brain stops working. Memory, so changes from, my gosh, I can't remember, I should know this. I resign. They'll come back. And this is what happens when you sleep for 2 hours last night. So complex Parkinsonism, spontaneous Parkinsonism, complex hallucination, fluctuation in cognition, and also lastly is a random eye movement in the sleep problem. When you sleep, you go into deep sleep, right? That's where your brain starts to regenerate. As you become older, we don't do that much. So we have to somehow take naps in the day. Okay? Easy. But imagine that we can't for whatever reason. So it's important that if you don't acknowledge that people with dementia, if let's say a tiger comes to you, will you stay there and smile? No. You would decide. If you were to stay, the tiger would eat you. Right? But someone with dementia thinks, if I come to you, what do you want from me? Are you trying to ask something that I don't have? That might not be. Then the response would be like the 100-year-old grandmother, right? Why are you keeping me here? So it's important that we need to become like Nancy Drew or the Sherlock Holmes of this industry. We have to make sure understanding what type of dementia, severity, the change behavior, the grading from the triangle, and then hopefully working with a big team, we can get a better response. Now, change behaviors. Primary, this is the old term, BPSD. If someone comes to me under my care, I said, Mrs. So-and-so, primary behaviors of concerns are depression, agitation, anxiety, hallucination. So the primary factor today is to help with anxiety, start a small dose of antidepressant, engagement, support the family, change the environment, put the nightlight on, example. You know what I mean? So we must address each problem with a probable solution. Make sense? These are the list of change behaviors. Example, wandering. Some people wander. Example, when I was in England, someone called Isla, she was a writer, a sailor, never been married. At the time she was 88 years old. She has frontotemporal, non-fluent type aphasia. That means the words are hard coming. And she wanders in the ward. And she always said, I'm looking for my eggs. And one day I came to work and I saw 4 security guys surrounding her. Whatever for? She's 88. How can she do to people? She just wants to find her eggs. But her eggs means she go to the nurse's station, go to other. And then I came and I said, Isla, come, hold my hand. Come. You again. So you stand here, sorry. This is, you got Isla. So you stand there and look at the audience. I'll come in, oh, Isla, oh, I'm so glad I found you, I miss you, I'm glad I let you look at me. Who's this strange guy? Oh, thank you, I'm so glad. Now, let's go for a walk. Is it okay? Is it okay if I were to do like that? Oh, let's do like this. Sorry about this, it's you. Oh, look at that. Oh, yeah, I'm sorry. Are you okay? Let's walk together. You start first. Now, I think I know what. Are you looking for your eggs?
Yes.
Yeah, can you look and smile? So the eggs are a pair of shoes. So I told the 4 big guys, go away. I said, thank you, let's go back to your chair. Sometimes it's good to pretend that you're searching them, like, oh, I found you. Maybe they think that they actually got missed, so we know them for real. I don't know, but I'm trying to help her. And I know from being my patient, eggs are shoes to her. So I said, I know what you want, eggs, shoes. Okay, let's find them. Solve. Sometimes we might not resolve it, but that's okay, at least we tried, right? So the story with Isla means everything must be A, B, C, D, an antecedent. What started it? X, no shoes means behavior, you know? And we, ABC, and then the cause of it, distress to the nursing staff, because she kept on coming and asking them, like 20 times in an hour. And then we have to de-escalate it, have signs, X and shoes are the same thing. Ask the family to bring many eggs, many shoes, I mean. That's what we do. Sometimes things like that do not need, because the person's visual understanding has changed. We need to become the experts. Now, I'll teach you how, if you haven't got Alzheimer's and you want to learn and how to teach others, you do this. Can you imagine how many years ago this was, Brenda? 10, 20, Denise, 30,000, Neanderthal, primitive. They have to hunt. You know, Graham, 30,000 years ago, people have to live primitively, right? They have to hunt. They use whatever lint or whatever stone, make it into a sharp spear and hunt and kill. At that time, these giant elephants were called mammoth. The mammoth needs to be killed. Do you think the mammoth would present itself in front of the house of those people? No! They have to hunt. You have to run. You have to kill. And do you think you can bring back one big mammoth back to the cave? No. But you must remember when to come back the next day. Correct? So if you kill this mammoth 10 miles away from your cave or your camping or whatever, you must remember, because to kill them is not easy, you know. So human beings were created because they have to run, they have to jog, so they can get the beast as their food. So now the word treatment to cure Alzheimer's is this. What if we know in our muscle cells there's protein as we walk, as we aerobics, as we fun aerobics, as we jog, as we walk along the beach or along the pier, we squeeze muscles in the arms and the legs. And that protein will go memory protein, muscle memory, correct? Goes here, past the blood-brain barrier that usually protects the brain from us getting meningitis, goes up and let us remember where we left the elephant mammoth last night. Okay? So do you walk 10, young person, 10,000 steps per day?
Yes.
I don't. How many steps do you walk, Denise?
Not 10,000.
I 4,000 only. Lady, you walk 20,000 steps per day?
Oh, definitely.
Do you walk golfing 10,000 steps per day?
Oh,
You try.
yeah, I try.
What about you, Robert?
Oh, less than you, because I play straight.
Yeah. Naughty man. That's not fair. What I meant to tell you, if you can do this, I talked in Malaysia, in Kuala Lumpur, to a lady who's on a wheelchair. She was 90. I said, Auntie, I'm sorry, I'm being silly, but what if we were to lend you, you know the ankle strap is in aerobics, ankle straps, half a kilo. What if you can do that? Because let's put the music on, let's do this, Auntie, together. Muscles, protein, memory. As the memory is excited from muscles, you remember them. So number one tip from today, from tomorrow, minimum 10,000 steps or 10,000 activity that equivalent, okay? One, if you do that, hippocampus is something that is powerful. The part of the brain that makes you remember 5 items. Now, those memories become episodic. Long, what were the 5 items again? Church, faith, race. Yeah, you go. Those become imprinted in the part of the brain left and called hippocampus. Hippocampus in Greek translated to English means seahorse. It does not look like seahorse, but whatever. It's there. I'll show you a nicer photo. That part, when you transect it, looks like the slide after immunology. It looks like this, colorful, right? So those 5 photos with your limbic system, you want it. You took control of your limbic, your emotions, and that becomes so powerful. You remember it next year. When I come back next year, hopefully you remember it. 5 words. Imagine that we do those things, but you must remember things that makes you happy, right? Like golfing, for instance. Do you like cooking, Graham? So don't drink one more. Let someone else do it better, like you do. What I meant to say is, those parts of the brain anatomy called memory is called dentate. It looks like jaw, dentate. That makes you remember me. Okay? That's what makes you remember eventually how long you've been together and loving each other forever. Understand? So to make this work, you must exercise. Otherwise, these people come with age. Let's age gracefully. We cannot stop this yet. Jess doesn't want me to examine whether she's got this yet. It's not your fault. Nobody wants, by the way, to do it, right? But imagine that we in the future have something that we can give to people. So the latest treatment for early or pre-Alzheimer's is infusion of chemical that we have studied and searched for 20 plus many years in Adelaide, in Melbourne, in Sydney, in other places. Is to see, can we stop production of this thing called plaques? So all these deposits that you see that looks like mottled brown coffee are the substrates that kill brain cells called dentate or your hippocampus. Then it will go to other parts, your temporal, you know what I mean? These are the culprits. And this is one of the factors. There are many more. This is just like tau. This is one of the many talks. But these are the ones that we have something. It was approved last week called donanemab. It's done by a company called Lilly, led by the person called Rod Fanny. They're presenting it next week in Sydney at the Geriatric conference. They've passed stage 1. Stage 2 means how to do it, costing, and how to translate it to public exam. How long will you get that? I have no idea. It will cost per injection $4,700, but in America we know they give this already for some time. Per year is $90,000 because you must have a PET scan, MRI, because the infusion have got dangers like brain swelling or meningitis. So it's not but this one that we know is quite safe. But the government of Australia, the Medicare, must sit down on a round table and be dignified and give hope to people. Yes? That's right. Now, the reason why we need to protect this is the plaques. All the plaques that you see, the tangles, this mottled blue, go to the receptors and kill brain cells. The one that looks like a seahorse. We need to protect that. So exercise. Life is short. Smile. Now I'll show you. Now it becomes a bit more technical. Now I'm so sorry, Lane, if it becomes technical, but let me know if it does. Let's say I want to be a good memory specialist, which I pretend to be every day. I will tell them, in Port Lincoln, I only have a CT scan. In Adelaide, I have all the scans. I have an MRI that can tell me the microstructure, hippocampus, parts of the lobe, fusion. I can contrast it. I can do a PET scan. A PET scan is high-tech. It's called positronic. It actually can detect the smallest volumes of change. It can make it colorful. It can tell you the colors of the brain and to the depth of how many parts are working or not working left. So I can predict 40% left of the green and the blue must be Alzheimer's. 40% loss of the green and the orange must be FTD. This must be vascular. It's so clear. I don't have to guess anymore. It's so easy. But everybody is different. It doesn't mean the person will have this problem. So we have to go back to the basics, the clinical finding manifestation. And that's why working with like health, the OT, social work, nurses, community is so important to preserve the function. The medication, the best medicines in the world, after doing all of the scanning, only works in 25% success rate. You know that? 1 in 4. The best brain drugs in the world work 1 in 4 only because of the side effect profile. We still do not know. Time.
Got a couple of minutes.
Couple of minutes. So what I'm trying to say is that imagine that if I were to look at someone's brain and the person is 80 years old, I would tell them, okay, number 1 to number 3, 1, 2, 3, 4. So this is the brain of someone without changes, what we call shrinking of global cortical atrophy. So we do a scan, it could be a CT MRI. We look at the picture from the top. Let's say we look from the feet up or head down. You can see number 3 or number 4 picture, you can see the brain starts to shrink. All of us will be in that stage where we lose brain cells every day. We are all terminal from cell perspective. It doesn't mean you have this, you have dementia. It just means your brain is shrinking with age.